Hi everybody, and welcome to our first video on cardiovascular pharmacology. Let's start by talking about beta blockers. Beta blockers are drugs that block beta adrenergic receptors. And in terms of pharmacology, there are two important types of beta receptors. There are the beta 1 receptors, which are found in the heart, and there are the beta 2 receptors, which are found in the lungs and also in the peripheral vascular system. We'll start by talking about beta blockers that are selective for the beta 1 receptors. These are mostly going to work on the heart. Drugs in this class include atenolol, metoprolol, esmolol, and bisoprolol, and these drugs are very commonly used for hypertension. By blocking beta-1 receptors, there's less heart rate and less contractility, so there's a slight fall in the cardiac output, and that lowers the blood pressure. Metoprolol has a special indication in systolic heart failure, patients who have a reduced left ventricular ejection fraction. In those patients, if you administer metoprolol chronically, it blocks sympathetic stimulation of the heart, and this blunts a pathologic process called remodeling, and that leads to lower mortality. So we often give metoprolol to patients who have a cardiomyopathy and chronic systolic heart failure. Other beta blockers are called non-selective because they block both beta 1 and beta 2 receptors. Drugs in this class include propranolol, timolol, and nadolol. Nadolol and propranolol are often used in patients who have portal hypertension. The reason they're used here is because the beta 1 blockade lowers the cardiac output and the effective circulating volume, and that lowers the blood pressure, so this can slightly decrease the pressure in the portal system. But in addition, by blocking beta 2 receptors, you decrease portal blood flow because there are many beta receptors in the portal system that, when activated, lead to vasodilation and more portal blood flow. So if you block those beta 2 receptors, you cut off the blood flow to the portal system, and this can lower the portal blood pressure. Timolol is often used in glaucoma as an eye drop. That's because beta 1 and beta 2 receptors are found in the eye. When they're activated, this leads to production of aqueous humor. So if you block those, there's less aqueous humor production and therefore lower pressure in the anterior chamber of the eye. And then finally, propranolol is often used in hyperthyroidism. It's the classic beta blocker to use in a patient who has hyperthyroidism. That's because in addition to blocking sympathetic receptors and slowing down the heart rate, which can be fast in thyroid disease, it also blocks the conversion of T4 to the more active T3, and this minimizes some of the symptoms of hyperthyroidism. There are a couple of beta blockers that block not only beta receptors but also alpha-1 receptors. Alpha-1 receptors, when activated, cause vasoconstriction, so when you block them, you lower the blood pressure. Labetalol is a drug in this category. It's often used in hypertensive emergency. That's because it can be given intravenously for a rapid reduction in blood pressure. Carvedilol is another drug in this class. It's used just like metoprolol in systolic heart failure. It blocks sympathetic stimulation of the heart, and it's been shown in clinical trials to decrease the rate of remodeling and reduce mortality. Let's talk about the side effects of beta blockers. Beta blockers are famous for causing fatigue, erectile dysfunction, and depression. In actual practice, these side effects are relatively uncommon. These side effects were originally described with older beta blockers like propranolol, and the newer beta blockers cause far less fatigue, erectile dysfunction, and depression. Beta blockers can cause a very mild hyperlipidemia. Usually it's an increase in triglycerides and a small decrease in HDL. And the effect varies with different beta blockers. And this is really only important in people who have very severe hyperlipidemia. In those patients, you sometimes need to be aware of beta blockers. We use beta blockers all the time in diabetics, but classically it is taught that you need to be careful administering beta blockers to patients with diabetes. There are two reasons for this. First of all, beta blockers block the effects of epinephrine, and one of epinephrine's effects is to raise glucose levels. So when you block this, this can lead to hypoglycemia, especially if the patient is taking insulin. So in a patient on insulin who takes a beta blocker, you could, in theory, see the patient become hypoglycemic, although this rarely happens in actual practice. Also, beta blockers block the effects of the sympathetic nervous system, and if people with diabetes take too much insulin and become hypoglycemic, they may be unaware of this. That's because they won't have the usual sweating and tachycardia that you would see from hypoglycemia. So beta blockers are said to mask the symptoms of hypoglycemia. So potentially a patient could get hypoglycemia, not sense it because they're on a beta blocker, and then have a seizure from hypoglycemia. Once again, this rarely happens in clinical practice, but this is something you need to be aware of, especially for board exams. Besides diabetes, there are some other clinical situations where you have to be cautious with beta blockers. One of them is asthma and COPD. So beta 2 receptors in the lungs cause bronchodilation, so if you block them, you can cause bronchoconstriction, and in theory, you can cause a flare of asthma or COPD. You can cause a worsening of the symptoms. Often nowadays we use beta-1 selective beta blockers like metoprolol. These are said to be cardioselective, and usually the effects on the lungs are minimal. And in general, we give beta blockers to lots of patients with asthma and COPD. You also shouldn't give beta blockers to patients who have decompensated heart failure. That's because when you block the beta-1 receptors in the heart, you lower the cardiac output, and that makes their symptoms worse. Now, having said this, we commonly give beta blockers to patients with compensated heart failure, and the key word is compensated. So once patients are out of the acute phase of heart failure, they're no longer dyspneic, they no longer have pulmonary edema, we give them beta blockers for the long term because they have a mortality benefit. But we generally avoid these when the heart failure is decompensated, meaning the patient is sick and in the hospital with pulmonary edema and symptoms of heart failure. You can overdose on beta blockers. Usually this occurs in elderly patients who accidentally take too much of the wrong medication. This leads to depression of myocardial contractility and shock. These patients will present with hypotension as well as bradycardia and even sometimes AV block, because by blocking the receptors in the AV node, you can cause various forms of AV block. And the treatment, and you always want to know this for your boards, this always comes up on the boards, is glucagon. So you may be wondering why glucagon is used. The reason is because it activates beta receptors at a different site from norepinephrine. Basically, it gets around the block of the beta receptors caused by beta blocker overdose. And this can increase the heart rate and increase contractility, and you can administer glucagon until the beta blocker overdose is washed out of the system. Next, let's talk about calcium channel blockers. There are three major classes of calcium channel blockers or calcium antagonists. The first group are the dihydropyridines, and drugs in this class are drugs like amlodipine. The other two groups are usually referred to as non-dihydropyridines because they have similar effects, but their technical names are phenylalkylamines like verapamil and benzothiazepines like diltiazem. And all calcium channel blockers can function as vasodilators if they cause smooth muscle relaxation in the peripheral vasculature, or they can function as negative chronotropes and inotropes if they block the entry of calcium into myocytes in the heart. So the dihydropyridines like nifedipine and amlodipine are predominantly vasodilators. Their major clinical effect is to relax vascular smooth muscle and cause a fall in peripheral vascular resistance, and this leads to a drop in BP, and we'll talk in a minute about how these drugs are often used for hypertension. The non-dihydropyridine drugs like verapamil and diltiazem predominantly affect the heart, so they have effects that are similar to beta-1 blockers. Their main clinical effect is to lower the heart rate and lower contractility. Another way to think about this is that the vascular smooth muscle effects are greatest with nifedipine and lowest with the other types of drugs. The heart rate contractility effects are greatest with verapamil and diltiazem and least with nifedipine and the dihydropyridines. So as I just mentioned, the dihydropyridines like amlodipine and nifedipine are great drugs to use for hypertension. This class is one of Dr. Ryan's favorite drugs to use for hypertension because they are very effective and most patients have no side effects. Some patients will develop flushing, headache, or hypotension. These effects are all mediated by the peripheral vasodilation. And then the one special side effect of calcium channel blockers that are dihydropyridines you need to know about is edema. These drugs cause vasodilation of the pre-capillary arterioles. And what that means is they allow the capillaries to be flooded with fluid, and this can potentially lead to edema. And this would present with lower extremity edema just like what's shown in this picture here. Most patients don't develop this complication on lower dosages, and when they do develop it, it's not serious or life-threatening, but it can be a nuisance. The non-dihydropyridine calcium channel blockers like verapamil and diltiazem can also be used in hypertension. They have effects similar to beta blockers, and they lower the cardiac output and lower the blood pressure. But because they affect the heart, in addition to hypertension, they can be used in some forms of heart disease. So we often use these drugs in patients who have arrhythmias like atrial fibrillation to slow down the heart rate. You can also use them in patients who have stable angina. They will lower the myocardial oxygen demand and improve exercise tolerance. Because these drugs affect the heart, you have to always remember that they are negative inotropes, and therefore they are generally contraindicated in patients with systolic heart failure. We don't want to drop the cardiac output any further in a patient with systolic heart failure, and these drugs have no special benefit in systolic heart failure, so there's generally no reason to use them in that circumstance. Let's talk about other side effects of calcium channel blockers. All of these drugs can potentially cause constipation. That's because they block calcium receptors in the GI tract, and that can lead to decreased motility. This is most commonly seen with verapamil. And then a very rare side effect, but one that's high yield to know for your boards, is hyperprolactinemia. This occurs with verapamil, and it can happen because verapamil blocks calcium channels in the central nervous system, and this can decrease dopamine release. And dopamine normally suppresses prolactin secretion, so when you decrease dopamine release, prolactin secretion goes up, and this can potentially cause symptoms of hyperprolactinemia. So this can lead to galactorrhea in men and women. It can also lead to hypogonadism. In men, this will present as decreased libido or impotence. In premenopausal women, it can present as irregular menses. Gingival hyperplasia is a very rare side effect of calcium channel blockers. It's been described with all types of calcium channel blockers. It's also been described in patients taking phenytoin, which is an anti-seizure drug, and cyclosporin, which is an immunosuppressant. And the gingiva are the gums, so if you look at this person on the screen, he's got hyperplasia of his gums. That's gingival hyperplasia. For the remainder of this video, I'm going to talk about antiarrhythmic drugs, and before I do that, I want to review the Vaughan-Williams classification system for antiarrhythmic drugs, because this is how these drugs are described. So this classification system breaks down antiarrhythmic drugs by the way they affect the cardiac action potential. So the class 1 drugs all affect sodium channels. The class 2 drugs are beta blockers, which we've already discussed. The class 3 drugs affect potassium channels, and finally the class 4 drugs are calcium channel blockers. So we've already talked about beta blockers and calcium channel blockers, but what I'm going to do in the next group of slides is talk about the class 1 and class 3 types of antiarrhythmics. Let's start by talking about amiodarone. Amiodarone is a class 3 antiarrhythmic, and like all class 3 antiarrhythmic drugs, it blocks potassium channels in myocytes. And anytime you block potassium channels in myocytes, you can prolong the QT interval on the EKG. To understand this better, let's look at my drawing on the top right side of the screen here. In black is a normal cardiac action potential. In blue is the way the action potential changes in patients taking amiodarone. By blocking potassium channels, amiodarone causes delayed repolarization, and that makes the action potential take longer to occur. And anytime you stretch out the action potential and cause it to take longer to occur, you can increase the QT interval on the surface ECG. In addition to class 3 effects, amiodarone is special because it does have some effects like class 1 drugs, which block sodium channels, and like class 2 and 4 drugs, which are beta blockers and calcium blockers. The most important of these effects is that it also can slow the heart rate slightly, and that's because of these other antiarrhythmic effects. Amiodarone is a highly effective drug. It's probably the antiarrhythmic we use most commonly in cardiology outside of beta blockers and calcium channel blockers. It can be given to suppress atrial fibrillation and keep patients in sinus rhythm. It can also be given to suppress ventricular tachycardia in patients who have malignant ventricular tachycardia. Amiodarone is highly lipid soluble, so it accumulates everywhere in the body, in the liver, in the lungs, in the skin, and other tissues. And if you know this, it's an easy way to remember that amiodarone has lots of side effects in different organ systems. The half-life is about 58 days, so in a patient on amiodarone, if you stop the drug, the amiodarone effects will persist for a long time. One good thing, however, is that it has biliary excretion, so it is safe in renal disease, and many patients with arrhythmias have kidney disease, so this is a good feature of amiodarone. Amiodarone has lots of side effects that you will read about related to accumulation of the drug. This probably won't come up in your boards, but you should know this clinically, that all those side effects are very unlikely at lower dosages, so very few patients in the modern era will experience these side effects. In addition, the risk accumulates over time. So for example, in a young patient taking indefinite therapy, there is a lot of risk. In older patients, especially if they're only going to take amiodarone for a short period of time, the risk is very, very low. So most of the patients you will see clinically taking amiodarone will not have any of the many side effects that can occur. So now let's talk about all those side effects. First of all, amiodarone has iodine in it, and the word iodine is in the name of the drug. And if you can remember that, and if you know that thyroid hormone contains iodine, then it's easy to remember that amiodarone can cause both hyper and hypothyroidism. In addition, it accumulates in the liver, so it can cause increased LFTs. Usually this is asymptomatic and mild, and you only stop the drug if there's a marked elevation of liver function tests. Amiodarone accumulates in the skin, and it makes patients sensitive to the sun. Patients taking amiodarone often easily sunburn and begin looking like this man, and they often have to avoid the sun or wear very highly protective sunscreens. Many patients taking amiodarone experience photosensitivity and easy sunburning, but a more serious side effect that's luckily very rare is a blue-gray discoloration of the skin. This is called the blue man syndrome. It's usually most prominent on the face, and patients who have this complication of amiodarone will look like this man shown on the screen here, a very rare side effect in the modern era. Amiodarone also has effects in the cornea of the eye. That's because amiodarone is secreted by lacrimal glands into our tear ducts, and it can accumulate on the corneal surface. This will give an appearance to the cornea known as cat whiskers. This is an example of it right here. You can see all these white wispy things here. Usually this doesn't cause vision problems, but it is seen in many patients on chronic therapy. You don't need to stop the drug if this side effect occurs. The most dangerous side effect of amiodarone is pulmonary fibrosis. This is the most common cause of death in patients taking this drug. On biopsy, what you see are what's known as foamy macrophages in the air spaces. These are macrophages that have accumulated amiodarone and phospholipids. And on chest x-ray, the classic pattern of severe pulmonary fibrosis is honeycombing, like shown on this example here. So on your board exams, what they're going to ask you about amiodarone is what test should be ordered when you're starting the drug. And I've written the tests on the screen here. We always do a chest x-ray before we start the drug because we want to know if there's any pulmonary fibrosis present before starting amiodarone. We always do thyroid function tests, which is usually just a TSH, but sometimes a TSH plus T3 or T4. And we always do liver function tests like AST and ALT. Sometimes we do pulmonary function tests, not always, but you can do these to establish a baseline, which you can use for comparison later on if the patient develops potential pulmonary fibrosis. So amiodarone is far and away the most commonly used class 3 antiarrhythmic drug, but I'll briefly mention some other class 3 antiarrhythmic drugs. Just like amiodarone, all of these drugs block potassium channels in the heart and can prolong the QT interval on EKG. The first two drugs I'll talk about is sotalol and dofetilide. These are commonly used in patients with atrial fibrillation. So for example, in a patient who has recurrent episodes of symptomatic atrial fibrillation, we will start sotalol or dofetilide. Then the patient will undergo a cardioversion to restore sinus rhythm, and because they're taking these drugs, the sinus rhythm will persist. And that's the benefit of these drugs. They suppress atrial fibrillation. And this is also the way we use some other antiarrhythmics like amiodarone, propafenone, and flecainide. Same idea in atrial fibrillation. You cardiovert the patient after they've been loaded with the drug, and the drug keeps them from reverting to atrial fibrillation. Ibutylide is also a class 3 antiarrhythmic drug. It's given intravenously, and it has a short half-life. And ibutylide can be used for chemical cardioversion. So when a patient has atrial fibrillation, like shown on the left side of the screen here, and you want to restore sinus rhythm, there are two ways to do this. You can give the patient anesthesia and administer a shock, and that will cause the patient to go into sinus rhythm. That's called an electrical cardioversion. But an alternative is to administer ibutylide. You don't have to give any sedation, and many patients will convert after ibutylide from atrial fibrillation to sinus rhythm. The downside here is that this can cause arrhythmias like torsade de Pointes. So that's a nice segue into torsade de Pointes. So all the class 3 antiarrhythmic drugs prolong the QT interval. And if your QT interval gets prolonged, you're at risk for a special form of ventricular tachycardia called torsade de Pointes. It gets this name because the QRS complexes go from bigger to smaller to bigger, and this was thought to look like a twisting of the points, and that's what torsade de Pointes means. This is a life-threatening complication of class 3 antiarrhythmic drugs. Of the class 3 drugs, amiodarone is the least likely to cause torsade de Pointes, and that's why it's used much more commonly than the other drugs in this class. Back to this slide of the Vaughan-Williams classification system. Now we're going to talk about the class 1 antiarrhythmic drugs. All of these drugs block sodium channels, but they are subdivided into class 1A, 1B, and 1C drugs because even though they all block sodium channels, the different subgroups have slightly different effects on the cardiac action potential. This slide shows the effects on the resting action potential in the heart of the different groups of class 1 drugs. So let's talk about this now. So this portion of the action potential here is depolarization of myocytes, and that's mediated by sodium channels. This portion here is repolarization, and that's mediated by potassium channels. So I've cleared away my ink, and I'm showing you here in blue a normal action potential, and in red the action potential after exposure to one of the sodium channel blocking class 1 drugs. The class 1A drugs cause depolarization to take longer to occur. Anytime you do that, the QRS interval can prolong on EKG. They also cause repolarization to take longer to occur, so just like the class 3 drugs we already talked about, class 1A drugs can prolong the QT interval. We'll jump over here to the 1C drugs. They really don't have much effect on repolarization, so the QT interval usually does not change, but they cause depolarization to take much longer to occur, and therefore they can prolong the QRS interval. And then the 1B drugs are kind of funny drugs. They generally have no major effect on the QRS interval, and they can actually slightly decrease the QT interval. All right, so let's talk about the class 1A drugs first. The major drugs in this class are quinidine and procainamide. And if you remember the action potential here, both of these drugs cause the depolarization to take longer to occur, so that can prolong the QRS interval. And they cause repolarization to take longer to occur, and that can prolong the QT interval. The second effect is because in addition to blocking sodium channels, they have some impact on potassium outflow from myocytes. Quinidine is an oral drug. It can be given to patients to reduce the recurrence rate of atrial fibrillation. It's associated with an increase in mortality, so we rarely use it in the modern era except under very special circumstances. Procainamide is usually given as an intravenous drug, and it slows conduction in accessory pathways in patients with WPW. This is its major use. So in patients who have arrhythmias associated with the Wolff-Parkinson-White syndrome and bypass tracts, procainamide is often the drug that we use, and that's what you want to remember about it for your exams. Another famous feature of procainamide is that if you give it in oral form for prolonged periods of time, it's associated with drug-induced lupus. Other drugs that can cause drug-induced lupus are isoniazid, used to treat tuberculosis, hydralazine, which is a hypertension drug, and procainamide, which we're talking about now. So what happens when patients get drug-induced lupus is they present with a rash, arthritis, and anemia, and they can have positive anti-nuclear antibodies, so this will look like a case of lupus. A special feature, however, that makes drug-induced lupus different from regular lupus is that antihistone antibodies are only seen in drug-induced lupus. So those will be positive in a patient taking procainamide who develops this complication. And all these symptoms of drug-induced lupus resolve when you stop the drug. The class 1B drugs that are important are lidocaine and mexiletine. These are both sodium channel blockers, and I've shown their effects on the action potential here, but really for this group of drugs, the effects on the action potential are not particularly important. What is important to know about these drugs is that they like to bind sodium channels in the depolarized state. So when are there lots of myocytes in the depolarized state? Well, it turns out that that's when there is ischemia. This leads to more depolarized myocytes. For that reason, these are effective drugs in ischemic arrhythmias. These drugs are also more effective at fast heart rates. That's because when myocytes repolarize, the drug unbinds, but if the heart rate is fast, there's less time to unbind before the sodium channels open again and become depolarized. So if you understand these things, you can understand that the main time we use these drugs is in ischemic ventricular tachycardia because you have fast heart rates and you have ischemia leading to depolarized sodium channels. So lidocaine can be used in patients with ventricular tachycardia in the setting of ischemia. You can also use amiodarone, and most people use amiodarone instead of lidocaine. Mexiletine is an oral drug and it's very rarely used in the modern era. You may know that lidocaine is also a local anesthetic. That's because it can block sodium channels in peripheral nerves to provide anesthesia. And the main side effects of these drugs occur in the brain and in the heart. So in the brain, these drugs can cause CNS stimulation. This can cause patients to have a tremor or become agitated. And if you see tremor in a patient on mexiletine, this is generally a sign of mexiletine toxicity. And then the effects in the heart, which are what are beneficial about these drugs, can also become excessive. If you block too many sodium channels, patients can develop bradycardia, heart block, and hypotension, all potential side effects of class 1B drugs. I'll finish with the class 1C antiarrhythmic drugs. The two important drugs in this class are flecainide and propafenone. These drugs are used for suppression of atrial fibrillation in patients with symptomatic recurrent AFib. Importantly, these drugs are only used in patients with structurally normal hearts. Patients who take these drugs must have normal LV function and no significant valvular disease. The reason for this is there was a famous trial many years ago, and in patients who had abnormal hearts taking these drugs, there was an increase in mortality. So we reserve them only for patients who have normal, healthy hearts. And the major adverse effect is that when patients exercise, these drugs increase their effects, and this can potentially lead to prolongation of the QRS interval, which can lead to ventricular tachycardia. So you want to know this for your boards. In any patient taking these drugs, we often refer them for a stress test because we want to see what happens when they get their heart rate up. If their baseline EKG looks like this, and with exercise it looks like this, that's very bad. That means that every time that patient exerts themselves, their QRS is widening and they can potentially develop a cardiac arrest. If you see this with exercise, you need to stop these drugs. So I'll finish with just a general point about antiarrhythmic drugs. The class 1 agents, the sodium channel blockers, and the class 3 agents, the potassium channel blockers, have all been associated with increased mortality in a number of trials. For this reason, we only use them when absolutely necessary. So in someone having recurrent ventricular tachycardia, which is life-threatening, we will use these drugs. In someone with highly symptomatic recurrent atrial fibrillation, we will use these drugs. But we never use them for benign things like PACs or PVCs, and this is something they're going to ask you on your board exams. If they describe a patient who has PVCs on the monitor, you don't want to give them one of these drugs because you will increase the likelihood that that patient will die, and PVCs are generally benign. And that concludes our first video on cardiovascular pharmacology.